simple, and then we're going to move on, and every time we're going to pass this back and forth like we did yesterday, okay? So it's a little hard. Okay, let me start with this one. My doctor says I have acquired Cvid, and if it's not primary, what is the difference? And I think the answer to that is that acquired immune deficiency, the acquired Cvid, was a name that was applied somewhere back around 1970 or so. So it's an old term that we don't use now, because now we consider that this is what we call, you were born with it, so you didn't acquire it. But it also means that it might not have been obvious until you were 20 or 30 or 40. But it's kind of an old term, and we don't actually use it much anymore, just for that reason. So you're going to get that one. Is there a true test for Cvid? In other words, the antibody titers, are they the most accurate? The one you have to start with, of course, is you have to start with measuring the serum IgG, IgA, and IgM. Those are the immunoglobulins or the gamma globulins. That's where you start. So that's round one. And then round two is then you go back and you say, okay, we have a certain amount of gamma globulin. Then that would mean that you'd go and see if that gamma globulin has function or not, right? It's like, I always think it's like you could have salad oil in your gas tank, oil. Hey, it's oil. Can you drive with it? No. So there are people who have some gamma globulin, but it's worthless. It doesn't work. It has no octane, has no ability to get your motor turning over. So that's what the titers are for, is to find out whether the antibody that you have is actually functional. Ooh, this is a tough one. I'm going to give you that one. Sorry, I'm punishing him.
No, thank you very much. So I've got two here. The first one is, how accurate are trough levels while on immunotherapy? And I'm assuming that's immunoglobulin replacement therapy. And it's a good question because it highlights a number of different things. One is accuracy in terms of laboratory measurement. And in fact, I would say that this is immunoglobulin antibodies are very stable proteins, and when they're measured in the lab by often something called nephelometry, they are measured against an international reference standard. So one should be able to rely on the levels fairly well. Having said that, trough levels are, of course, one surrogate measurement for how well someone is doing and how well they're replaced. They're one piece of information, and there are many other pieces of information that one would put into the mix to work out whether optimal treatment was occurring. The trough levels, of course, also need to be taken at the right time. So often, if that's not on the form, it's hard to interpret. And I would say in Wales, where we have a large geography in terms of patients coming to one centre, we used to have 13 different laboratories measuring trough levels, and then we'd phone up their labs to check where the patients were. And we've changed that entirely now and switched to having everyone sends their trough levels to our central lab. So they have these little blue Royal Post Office click boxes, and the bloods go in and it just arrives the next day to our lab. So the nurses have spreadsheets where they track across everyone's levels over time, and sometimes there's an odd value and you then have to check whether that was taken just before the infusion. So I would say from a laboratory point of view they're very accurate, but they only form part of the picture, and they need to be taken at the right time, but they are stable in the post.
much health scare or health problem? In other words, could you get CVID because of trauma? I guess, right?
So I've just had some assistance with translating the end of this question, but the question is in and around, is it possible to end up with CVID because of trauma or other health issues? And in a way, following on from Charlotte's answer at the beginning, because it is a primary immune deficiency, we certainly believe that there is an underlying cause for this, which in some cases might be one gene or might be several genes polygenic, and that means that you have a predisposition, if you like, for at some point antibodies not to be formed properly, and that might be in your teens, but it might be much later in life. So we don't fully understand why they stop being formed when perhaps they were being formed before, but some have put forward a second hit hypothesis, such that there is something in addition that happens on a genetically predisposed background, and then antibody production declines. But our understanding of what that is or how that works, I think, is far from complete. So trauma, maybe not trauma, but there is something in and around this second hit that people have proposed, but much needs to be learned.
Yeah, that's a very complicated question, and I think we don't have a perfect answer for that. But what's the bottom line is that you read in lay magazines that various things can harm the immune system. I think it's a very popular thought. And I don't think that's what we're looking at here. We're looking at something where your antibody making is really just plain not good to begin with, and it's probably not going to be good. And that goes to the other question in that similar vein, which is, why are so many doctors quick to say that your immunoglobulins can't change over time? That's a tough one, because what your baseline level of production of gamma globulin is likely to stick around and be the same. If you're discovered to be hypogammaglobulinic, you're low G, low A, low M, frankly, they aren't probably going to go up and become normal. I don't think I've ever seen anyone go normal who was really, really low. But the reason why that's sort of not true is for two reasons. One is that if you've been treated with a medication, epileptic drugs, for example, or steroids, then your gamma globulin level when you're not on those medications could get better, because some medications could really lower your gamma globulin level. That's true. So I hope that answered that particular question. Your baseline's generally your baseline unless medications are giving you some additional suppression. I have one I'm going to try, but then I'm going to ask Todd to help me on this one too, which is that I heard there was some kind of disease deficiency that causes the fatigue of CVID. What is it, and where's more information about that? There is, a syndrome that none of us understand at all called the chronic fatigue syndrome. I think it's a different name in England.
No,
Same name, don't you have? Encephalomyel something or other?
Well, we understand CFS.
Oh, chronic fatigue syndrome, CFS. And it's really a big problem in some patients who do end up in the immunological world, because it acts to a certain extent exactly like an immune deficiency disease. The catch is the immune system, as far as I can tell, has very little that you can tack down about abnormality about it. So I don't know if that's what this person had in mind, but there is a lot of recognized of fatigue in people who have immune deficiency, especially I think CVID it's just a fact. There is more fatigue recognized in people who have that syndrome. So several things to say about that. One is purely on the medical side, and then I'm going to let Todd answer the part that's really what you want to know. On the medical side, if you've got a low-grade infection, sinusitis, you've got a cough, you're not sleeping well because you're basically needing more treatment, then that would definitely make you more fatigued. So that's kind of round one, is making sure that you are optimized with regards to the medical side. But now I'm going to turn this over to Todd, because fatigue is something that he can address from the standpoint of the other components.
First of all, I have to say that this thing here is a very dangerous weapon for me. My wife will tell you that I aspire to be a comedian, and now I have an opportunity to crack some jokes. So, big Godfather fan. If Sonny had Easy Pass, he'd be alive today. So, with that, fatigue. You know what? It takes me to, well, in sports. I'm not kidding here. There's a difference between being injured and being hurt. When you're injured, don't play. When you're hurt, you could push yourself a little bit. You could push yourself, you could keep on playing whatever respective sport that you're playing. I guess, you never hear this term like in the 70s, I am so sore. You just never heard that. Today, with all these gym rat type things you're doing, circuit training and all that, everybody's sore. And there's a difference between being sore and being hurt. Right now, my lats are killing me. I did some chin-ups yesterday for the first time in a while. But that won't prevent me from keep on working out. I'm not injured. I'm just sore or hurt, maybe, if you will. There is a definite push yourself component to going to the gym and having CVID. And recognizing the fact that when it was new to me about when I was doing all these basketball drills for the first time and I couldn't do it and I quit and I gave up, what I didn't realize was that I could do it. And when I realized that, that was a big moment for me to understand that you should or could push yourself. So that's a big thing. That's where it takes me, as far as maybe you could kind of tie in the being hurt and being injured component to having CVID and pushing yourself.
Do you have fatigue?
I think for me, it feels like normal fatigue. It doesn't feel like, yeah.
We're going to go to another section, and now we're going to talk about treatment. And Stephen's going to take the lead.
Okay. I've got a sizable mountain here on treatment, actually, and I'm going to start with a question about rapid push. And it says, what is rapid push and how does it work and side effects? Rapid push is, if you like, perhaps the most pared down and simple form of replacement, where in fact you don't have pumps or IVs. It's a subcutaneous treatment where you simply have the syringe and probably a butterfly needle, and you give smaller volumes. There's a absolute expert here at the meeting, Ralph Shapiro, and it's about 3 mils to maybe 20 mils, and you just put it up in the syringe, you put your butterfly in, and you can just feel what's comfortable and push that in. And so you might do that every day, or you might do it 3 times a week or 4 times, or depending on what your dose is. But it's smaller, and it's preferred perhaps if you just want to do something for 5 or 10 minutes in the morning and then it's gone. And you don't want to mess about with pumps. The side effects, I think, are probably similar or perhaps even slightly less, because the volumes are smaller, to normal subcutaneous infusions. But again, it has a very stable level because it's small and often. So the next question is, for a patient on subcutaneous immunoglobulin, what is the target Ig level you like to keep your patients on? And this is a really nice question, because the thing is, a target level is not about individuals really, and so the target level is the level that keeps that person right, I think. Now, when we start treatment, of course, you do have a kind of rough ballpark in mind. So, and that's based often on the weight of the patient. And so 0.4 to 0.8 grams per kilo. And also the cycle duration. So for SCIG, that might be twice a week, once every 2 weeks. And if I looked at my cohort and just took everybody and said, what is the average level? In fact, it turned out to be somewhere between 9 and 10. But certainly we aim for more than 7. And if people have things like bronchiectasis, we tend to push higher. Okay. What is facilitated infusion and what is rapid push? So facilitated is a relatively new way of giving immunoglobulin under the skin, but it uses an enzyme called hyaluronidase, which essentially opens up the otherwise gel-like matrix under the skin to allow fluid to permeate through, and the body turns this over very quickly so it kind of allows more fluid through and then fixes it all up within sort of 24, 48 hours. So that enables you to, instead of maybe giving 20 to 40 to 50 to 60 mils at one site, to give 700 mils or 200 mils or 500 mils, quite a lot more. So less needles and less infusions. And that's one we have more limited experience with than, say, intravenous or subcut at the moment, but it's certainly growing in our centre. Okay, so when should your doctor consider upping your meds? If your level is, and I think it's 1150, and you're always sick, if numbers don't maintain quality of life, well, this is absolutely key in terms of the feedback between the follow-up visits and what is actually happening in between visits. How many infections? How well are you? What's going on? And that actually is sort of, in my numbers, 11.5 grams. So that's a pretty good level. You might want to know what the sickness is. What are the symptoms? Because as we talked about yesterday, immunoglobulin is really, really, really good at some things, and other things, it's a challenge, like the sinuses, maybe like autoimmunity, actually. So it depends what those things are, and if you think they are amenable and due to infection, and it is because you have a level that isn't quite right for you, then some adjustment of that may be required. But also you might think about antibiotics and other things. It's the whole picture. Here, it's an ongoing conversation about whether those levels are right for that individual. Difficult to answer that properly accurately for you, I think. Okay, so is it normal in CVID to increase the amount and frequency of IVIG as one gets older? And reading this straight off, I wouldn't have said so unless there are symptoms or changes that make you want to adjust the treatment. But I think if someone is growing older, there isn't an automatic reason why one would need to increase that simply because of age. Is that fair? Yeah. Is there a difference between IVIG and subcutaneous immunoglobulin? Also, a very good question. I mean, obviously, there are the obvious differences, but behind those, intravenous, as you can well imagine, is quite an instant thing. It's into a vein, you get a very quick and high blood level, and that gradually drops over a period of weeks before the next infusion. Subcutaneous is quite different, actually. Under the skin, it has a totally different journey to get into the blood. because in fact it isn't absorbed into blood vessels, it's absorbed into lymphatics. And so that travels through the lymphatic system and then enters the venous system, and then you get a blood level. So it's actually got quite a journey to get to the blood, and hence you have you don't have the peaks and troughs, and you have a more stable level, but it does travel a different route. But both are very effective. Is it common to have severe side effects with IVIG? And is it common to have weekly infusions? So, severe side effects, I would really hope not. This is a very well tolerated medicine. If you're having severe side effects, I think one would need to review the treatment and why that might be. I would say virtually everyone that we have does not have pre-meds. If you're needing regular pre-meds and steroids, you think again. Is there something that's not quite right here? And there may be that a product does not suit someone perfectly and you have a good clinical reason to switch. But I think severe side effects would be a review of treatment and a review with the nursing team as well. Is it common to have weekly infusions? Do you know, for IVIG, I would have thought one of the advantages was that you would have probably infusions that were spaced out more than that, at 3 or 4 weekly. We do have a very small number on weekly or more frequent IVs, and they are, for us individuals, where we really struggle to maintain levels. And the ones I can think of at the moment are probably individuals who are have norovirus gut infections, where for some reason the requirement goes up very considerably, and we have to push harder to maintain the levels. Is a chest rash a common side effect from IVIG or sub-Q? I have seen skin side effects, but it's not so often, and so I wouldn't say it's a common side effect from either of those. Having said that, a common side effect from subcutaneous would be local reactions, and you might have local redness or swelling or itching, and you might have it in about 100% of people, and then that gradually declines over time. But simply the physical nature of a fluid under the skin, one would have a swelling. And then the second part of the question is about, does changing brands improve the rash? I think if there's a consistent side effect that is temporarily related to an infusion, one does have to give that serious consideration, although the rash here is not a common one for us, or not a common one that we see. For some with thin veins, which are small and poor venous access, is it possible to do a port, which is a kind of implantable device that's sometimes used to give intravenous access? And what are the risks of infections involved in that? My feeling about ports is that I really try to avoid them if I possibly can, because it's a foreign body, and there is then an increased risk of infection in a setting where infection is already an issue. And so we do have 1 or 2 people who've had ports or had ports historically, and but it's a very, very tiny number, and hopefully, I thought it was really loud before. Hopefully, subcutaneous offers possibilities if veins are poor, and certainly it's been a brilliant thing in children where it's very difficult to get venous access sometimes. What are the dosing protocols for CVID? Do they vary on each patient, trough levels, infections, etc.? Touched on this a little bit, but absolutely, they vary. This is individualized treatment, and so you start off with something that is fairly similar, and then you dose adjust based on the clinical response, how well someone is. The trough levels are a surrogate marker that we use, but they're not everything. And so I couldn't give you one trough level that would cover all patients, but I think if there were persistent infections, you would look to adjusting things, maybe immunoglobulin, maybe antibiotics, maybe there are different chest therapies if it's chest infection. Okay. Can I go in a hot tub? That's not the whole question. After my HyQvia treatment, and if not, how long after my infusion do I have to wait? It's tempting, isn't it? You know. With HyQvia, I mean, you do give quite a lot of immunoglobulin, which is then sort of gently absorbed over the next day or two. And some people do notice that gravity will move that fluid. So I think this has to be sort of in and around common sense, really. I probably wouldn't dive into a hot tub straight after you've got 700 mils under the skin. But you'd probably be fine the next day, I would have thought. Is that reasonable? I haven't tested it. Now, these are getting more tricky. Okay. Can cancer chemotherapy permanently damage the immune system in PI patients, particularly CVID? Are there... Oh, it's difficult to read. Are there any signs or drugs more likely to cause such danger? Well, I would say that we're learning much, much more about secondary immunodeficiency and medicines used to treat, in particular, blood or hematological malignancies, which are often malignancies of B cells, antibody-making cells. So hematology is getting very, very super clever at knocking out B cells. So we are seeing more patients who have low antibody levels because of those drugs. If I had to pick some out, probably rituximab, which destroys B cells, is a medicine that we are hearing of and seeing more in our referrals. Combination medicines, fludarabine and rituximab. So there are some that maybe have a more potent effect on B cells, but of course, depending on what's being treated, that may be absolutely appropriate and right to do so. But the recognition that it can have an effect means you're forewarned to look for an issue with antibodies and maybe step in and protect. So for CVID patients, I always have a very, it's a line to walk with immunosuppression in the immunodeficient. So we are often very cautious and look very carefully, but there are situations where simply those treatments will be required and one has to monitor and carefully adjust treatment on that basis. Okay, this is a challenging one now. When I was diagnosed with CVID, my IgG and IgA and IgM were low. After receiving SCIG, my IgG levels increased, as expected. But my IgA and IgM levels also increased significantly. Does this happen in other patients, and why does this happen? It's a very good question. As you know, the vast majority of immunoglobulin products contain IgG, but not IgA and IgM. And there are one or two that are available which do. So you would not expect to see an increase in A&M on infusions of IgG. So that makes me think that there is something else there that's causing that. It doesn't say whether they are normal levels, and I guess one would have to know whether those levels were variations occurring within just lab testing or actually a real trend towards normality. If that was the case, I think I would reassess that situation and ask about the antibody production capacity within that individual, both for G and A&M. But no, you wouldn't normally expect that. We're doing really well. I've just really stumbled on that hot tub question. So this isn't about hot tubs. It says, for someone with CVID and receiving intravenous immunoglobulin every 4 to 5 weeks, is it possible to stop treatment altogether and see how you are and how you feel? Well, it's a very good question. I mean, I think if one had absolutely clear and confirmed CVID, that category would mean that you would really benefit from being on immunoglobulin and being replaced into the normal range. 4 to 5 weeks is quite a long gap, so we would have very few people actually on 4 weeks, although that's our practice. Most would be on 3 weekly replacement. And I think it would be an unusual situation for CVID to simply disappear. Having said that, there are situations where you want to reevaluate whether there is any change or whether antibody production can occur. And that's really tough when you're on immunoglobulin, because you're, of course, simply measuring the antibodies that are in the immunoglobulin infusions. So one of the newer vaccines which we're looking at using for this is called Cvid, and so it's not present in immunoglobulin. So the levels are very low. So if you were to vaccinate someone who was on immunoglobulin and then the levels went up, those are not coming from the IVIG or the SCIG. They are then that individual's production. So sometimes you're looking for tricks like that to see if you can check antibody production while on immunoglobulin. The alternative, and what is perhaps being suggested here, is what might be termed a washout. So if you were to stop and obviously discuss the kind of risks and benefits of that, because no one can be forced to have immunoglobulin, you would then, over a period of maybe 3 to 6 months, reevaluate the immune system and ask, does it all just still drift down to very low, and are the infections coming back? And yes, it was really important that we kept it at 3 to 4 weeks, but there are some tricks there to try to look at people's immune function on immunoglobulin. Okay. If sub-Q enters the bloodstream through the lymphatics, oh, these are very hot questions. This is like hot off the press. And your lymph nodes are already enlarged, proliferative, and overactive on a PET-CT. Does the sub-Q treatment place more or extra stress on a system that already has a difficult time doing its job? Well, it's a really good question. I think if one envisages a situation where you have enlarged, proliferative, and overactive lymph nodes, in fact, that would be a situation where sometimes the immunoglobulin requirement would be higher because consumption would be greater, although that is very individual. I don't think the path of the antibodies would be impaired in getting to the bloodstream, though, because the lymphatics have what's called fenestrated, which just means like windows, in their lining, which allows large protein molecules through. So I'm not aware that there would be impediment to flow, but certainly in that setting one might see a potentially greater requirement or a greater dose needed to maintain the levels. If that dose is very high, then of course you might need more volume or more sites. And if the volume and sites became very high, you might make a call and feel that actually this is just too many subcutaneous infusions and I'd be better off with IV infusions. But those tipping points are also just very individual, and that's a discussion to have.
We need some yes and no's questions now. Okay, a lot of us donate platelets, which of course has difficulties, which of course not the least is the time involved. Any chance of platelets being made artificially? Not that I know of. Okay, if a patient does need a port, what precautions can be taken to hopefully avoid infection? Actually, you've just heard from Dr. Jolles and I've said this before in various rooms just like this one, I'm incredibly against ports. There's so many other ways to not deal with a port. But I do know that there are some people who have ports. But the first thing I try to do is talk a person out of it and to try to get it out. And the third thing is, of course, if it's there for another reason or for some reason it simply can't be done, although I have actually not had that occasion, very, very serious attention to cleansing, hand washing, only one person touching that port, all the other very, 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 very strict routines. I don't know if there's any other.
We have a small number and they have access because they have to have parenteral nutrition, so feeding into a vein, and that's often because of the gut problems or norovirus. And my clear impression is that if you have to have that for that reason, it is actually much safer that the patient looks after it than other people, because they are the most careful, the most trained, and the most safe person, once they've been obviously taught what to do, to protect that site. So it's a rare event, though.
It's a rare, it occurs. Do you let the TPN go to the same line as the IVIG, by the way?
Yeah, we had a discussion about this with the TPN, because they don't want our IVIG in there at all. So in the end, because of the access situation, we sat down together and discussed that we had to do it, and we simply separated them in time. But of course, the same absolutely scrupulous attention to hygiene for both things.
Certain autoimmune conditions that are most prevalent, yes. Low platelets and low red cells. Platelets are number one. Hemolytic anemia is number two. Number three is the combination of the above. Number three is possibly neutropenia. And those are the ones that are by far the most common. It's the blood circulating elements. Pernicious anemia is about, 6%, 7%. Rheumatoid arthritis is somewhere around 3%. Juvenile rheumatoid arthritis is much less common. Thyroiditis is perhaps the most common, but of course it's very common in human beings in general. So it's a little hard to say how different that is from normal subjects. I think autoimmune conditions might be a little bit more common in females, perhaps. Not sure about that, but perhaps that's the case. What's the link between lymphoma and colon cancer? That's a very tough one. Stomach cancer was actually the biggest one in many previous studies in CVID. My data, and that I think of the world right now, including USID-Net, is that stomach cancer is actually on the decline in the United States in general, and it's certainly on the decline in CVID. Colon cancer is it's not clearly increased, but it's potentially somewhat increased. The one that actually is the most increased in CVID is probably skin cancer. And there's a publication that came out yesterday about cancer in patients with primary immune deficiency in the journal Allergy and Clinical Immunology. No, it's in, Journal of Allergy and Clinical Immunology. But again, the numbers are small. In other words, all of us feel at risk, who have CVID, everyone would think themselves at risk. But then you think, well, what's the numbers? The numbers are still somewhere around 97% against, even if it's 3%. There's still 97% will not be having such issues. What's the link? I think it's a number of things at once. There's some genes that simply don't work correctly in B cells, and because of that, they may actually turn on an abnormal gene, which then could lead to a B cell lymphoma of some sort. For colon cancer, it could be that bacterial antigens in the intestinal tract aren't properly handled, and that could be a reason why in the GI tract it's been a problem. One in particular in the stomach was Helicobacter. You probably heard about that. That's a common cause of cancer in normal stomachs as well. You don't have to be immune deficient, but we use antibiotics a lot. And personally, I think the antibiotics are why we don't see the stomach cancer. That's one of my views. I'm going to try to hit some fast ones here.
I've got a fast one.
You got a fast one? Go.
Does IVIG interfere with genetic testing? No.
Okay, no. Okay.
That was the only fast one.
Okay, I'm gonna weigh in on this one, but I'm gonna see if Stephen agrees with me. I've been on IVIG since 2006 and pre-med with Benadryl and Tylenol every time I have IVIG every 28 days. You said this was something that was not needed. I do not have side effects doing it this way. I have to confess to you, I think nurses get into a routine. In other words, this is the way we've always done it. This is the way it happens every time you come in. This is the way the orders are written. And it's extremely hard for a order to actually get changed in the chart. But after a person's been on gamma globulin for, 3 or 4 or 5 infusions and all has been well, we generally do what you do, is we begin to take away the medications, the pre-meds and the Benadryl and such. And the other thing we do is we begin to speed up the infusion if it's IV, because again, nursing agencies oftentimes thinks it's a 4-hour, a 5-hour, a 6-hour, a 7-hour infusion. And of course, for most adults, you can get the gamma globulin a heck of a lot faster than that. Why waste your day, Why walk out feeling doped? Also, I don't like people to get Benadryl, go home, and drive home, and I'm thinking, they've just had Benadryl. That's not a good idea. So I don't like them to be sedated very much. So I would get the nurses to make an experiment and start to take that stuff back. What? Come to your house. Okay.
There's a very similar question about steroids and pre-medication here. About someone who has to pre-medicate and has had steroid psychosis. Is there anything else I can use besides steroids? I've tried 4 different IG products and I can't use sub-Q because my levels dropped very low. 4 different products and reactions, it is pretty unusual. I don't think we have any patient at all on regular steroids, pre-meds. Subcut, there may still be ways, because you can actually use subcutaneous in neurology settings, which is high-dose treatment rather than replacement. And that's been very successful in some centres. The other thing would be maybe to think about facilitated in that setting. But I'm sure there is a way, and a much better way than lots and lots of steroids, particularly with those side effects.
Go. Pick one.
Sure. I think this one is for Dr. Jolles. What's it like being so handsome?
It's not for me.
That's my... How do you manage high-level athletic training and competition along with the curveballs from PI? I have a tendency to overthink things. This one I don't need to overthink. It's discipline. It's total discipline. having CVID, I have limitations. One of them is right now I can't see you because my glasses are on. So with that, knowing that, can't dismiss that. Go to bed early. You wake up early. I work out. I wake up 4:45 a.m. every day. My wife and I, we have coffee, and then we hit it. We hit it hard in the gym every day. We go to bed. Well, I think if you were to read it on paper, we're boring. We go to bed early. We go to bed at 8:30. We eat well. At least we try to eat well. My wife has indulged a lot while we've been here, a lot of chips and stuff. Honey, I'm going to eat. I'm going to eat. Okay, eat. It's okay. I'm not going to judge you. But it is a fundamental thing, is discipline.
We have to call a halt to the question cards, okay? Right at the moment, because we have more than we can handle. But Todd, how do you handle the infusions, and tell people about that? How does that go?
It is a nuisance, I have to tell you, and that's a good thing. That is a good thing. And when I say nuisance, it's an inconvenience. It's just, and if it's an inconvenience, that's a good thing. You know, as much as it's a pain in the neck that I have to kind of stop, and in this case, not smell the roses, believe me. It's stop and get something in your arm and sit there for 3 hours. But I understand, I need this. This is something that enables me to live the life, the physical lifestyle, the active lifestyle that I live. As far as the infusion, I'm bad. I'm bad. When the nurse leaves, I kind of purge the thing. Now, for me personally, it doesn't affect me that much. I do get a little headachy. When I say purge, the drip, I make it a little faster. Does anybody, do you know that? She starts the IV, right? And I finish it, yes, yeah. And with respect to, yeah, I do feel a little flu-like, and I do have headaches and, you know, something of that nature or ilk, if you will. I just want to, you know, live my life. I have so many things to look forward to, but the primary thing that I look forward to is working out, and that's my OCD, and I think it's a good OCD, truthfully. Yeah, I do get a little headachy and flu-like, but fortunately it doesn't prevent me from living my everyday.
And no pre-meds, I think, right?
No.
No pre-meds.
No pre-meds.
He gets a very big dose.
Yeah, I do. Yeah.
I've got a different, entirely different question here. I've got CVID, and last year I suffered an attack of Guillain-Barre syndrome, which is a neurological disorder where you lose the strength in your legs and arms, and sometimes ability to breathe. I did not get a flu shot. Is there any known connection between CVID and Guillain-Barre syndrome? Should I get flu shots in the future? Are there any preventative measures to avoid GBS recurrence? This is it's a complicated question. So to begin with the flu side of things, we would in fact normally recommend that all of our CVID patients have flu vaccination, and the reason for that is not that we believe there will be a perfect or optimal antibody production from that, but that some benefit may be retained because of T cells, and maybe there will be some residual antibody, but predominantly the T cell side. There has been, I think historically back in the 70s, a relationship to a swine flu vaccine and a possible small increase in the background level of Guillain-Barre syndrome. That I don't think has been sustained more recently, and in general the feeling would be that you are probably, for Guillain-Barre, which is something like 100 and something people a week in the US, you're more likely to get Guillain-Barre from the flu than from the flu vaccine. So in this setting, I think the general recommendation would be protect where you can, even if it's not 100%. But of course, there are going to be individual and specific discussions that would need to take place. Reactions. In IgA deficient patients, what percentages react to regular IgG product versus low IgA product, considering switching from IVIG to sub-Q? So, in general, subcutaneous immunoglobulin replacement has fewer systemic, that is whole body, reactions, although IVIG is a very safe product as well. Companies have worked very hard to remove IgA from immunoglobulin, so it's trace amounts, except for one or two products, certainly in the European market. I'm not so sure about the US, where IgA is put in or left in, as is IgM. And I just wonder if the reactions that we talk about are actually less and less and less now, and that these are historical first and second generation products, and whether in fact it was ever the IgA, because the products are so much better now, and it's almost something that we need to revisit, because is there a use for the IgA in M? I think this is very much the same question. So in some patients where there are very high levels of anti-IgA antibodies, this was the concern, that if you gave IgA, that would react with the IgA in the infusion. And in fact, we don't know if that high level of anti-IgA antibodies is in fact even the most meaningful test for true allergic reactions, or if it's a surrogate test. I have one or two people where the levels are very high, and maybe we would choose a, what's called a lower IgA product, but in fact now they are all very low in IgA, and I think those reactions are less and less.
Sort of in the same vein, it's the same question. I know the package insert for one product, in fact, I think all products, but one in particular has a particular comment that this is one of the subcutaneous, that people with anti-IgA antibodies might have a problem with this subcutaneous product. The FDA actually insisted upon that language, even though, to be honest with you, I exactly agree with Stephen here, that the chances of a reaction through the subcutaneous route is probably infinitesimal, I think. I believe the Swedes proved that in people who had actually known IgA antibodies in their blood, and they used products by the subcutaneous route, and I believe it was entirely successful, as I remember. Wasn't that Jana's work? So we don't actually worry about it. It's something which you'll see on the package insert, but to be honest, it's one of those things that probably should be taken away, but the FDA continues to demand that it stay there, but I think it's medically a little bit undefensible.
As there was an interesting meeting in the UK, because we used to give EpiPens or adrenaline auto-injectors for people who did their own IV infusions at home, just in case they had a reaction. And in fact, a very large study was done from the Oxford group with Helen Chappell and her team, and they had no reactions on tens and tens and tens of thousands of infusions. So everyone in the room was asked, should we stop giving adrenaline injectors? And the entire room's hands went up, and from that day, no more adrenaline was given, because it had just proven its safety. I've got a mechanistic question here about, are the IgG immunoglobulins constantly being destroyed and replaced in the body, or is it a set level? If they're being destroyed and replaced, during what time of someone's day is the IgG being produced? So if one takes the normal situation of production and loss, IgG is being constantly produced, and it is then being used up because it binds to things or it's broken down, so a balance is struck and a level is reached between production and loss. And IgG is a remarkable protein because it lives so long. So it lives for weeks, 3 to 4 weeks in the blood. And that is because the body has a system to recycle it, which is virtually unique for antibody and albumin as well. And so I would say those processes are taking place all the time, really. What immunoglobulin infusions do is replace at the time that you give the infusion. So it's not like the constant from the bone marrow or from the B cells. So with IV, you replace and it comes down, you replace and it comes down. With subcut, it maybe mirrors the physiological constant production a bit more. But good question.
These are going to be a little bit more on the diagnostic issues, and this is a very interesting one here. My son is 15, and his IgG levels have gone from 596 to 470 back to 674 in the span of 4 years. And the question is, what's that all about? First of all, this might be a different laboratory. Remember, laboratories have their own sort of ways of doing things. That's number one. So if this was at 3 different laboratories, then I guess that's a little bit understandable. The first one was on the edge of normal. One of them was distinctly lower, and the other one was sort of on the edge, but a little higher. Remember that gamma globulin levels are only 10% accurate, because the nepilometer, which is the way it's done, is really only 10% okay. So if somebody's level is 600 or 700, remember it's plus or minus 70, right? So that's just kind of one place to start with. But my bet is that there's something either medication-induced, laboratory was different, or this is just a biologic fluctuation that, maybe this person has been on some medication in the meantime, or there was some other medical reason. But generally speaking, the levels tend to agree over time. There was actually a really interesting paper that I never saw published, which came from, I think, the Scandinavians, and I think they measured a bunch of normal people's gamma globulin level over the period of a month. And the honest truth is there probably is sort of a little bit of a circadian variation. I never saw that paper come to light, but I always thought it was a pretty nice thing, because it could be there are little bumps at times. Anyway, these numbers are all semi-similar. The other one is one I just wanted to mention because I thought this was a fabulous question, and I would like everybody in the room to know about it. If somebody's been on treatment and develops an autoimmune disease, which was diagnosed by symptoms and then finding antibodies, is there a way to know if the autoantibodies were created by the patient or by the gamma globulin treatment? That's a graduate level question, I have to tell you. And the answer is no. And doctors forget it right and left. So if you've been told that you have autoimmune thyroiditis based on a blood test, it's likely wrong, because there's a great deal of anti-thyroid antibody in commercial gamma globulin. We just have an article in press that says that you also can't diagnose stiff person syndrome, because that gamma globulin is got all the autoantibodies that normal people may have, and they are not sick, but they contribute that gamma globulin. So tell your docs that. If anybody tells you you have an autoimmune disease, be sure to check and see, was that really based on your blood, or what was it based on? So that's a tough one, and that's a fabulous question. Can CVID diagnosed in childhood be transient? In my experience, if you have a person who's diagnosed with CVID under the age of about 6, and the IgA and the IgM normal are getting into the normal zone, I would begin to challenge that diagnosis myself, because CVID and having low levels would be very hard to dissect. Transient hypogammaglobulinemia would be hard to dissect from CVID in the young age group. So I have not uncommonly taken a young person, 5, 6, 7, 8, or 9, off immunoglobulin to see whether the levels were really as low as one thought. And I would do that particularly if the IgA and the IgM were normal, because that tells you already that the B cells have got their job pretty good under control. Otherwise, those antibodies would not be in the blood. So it may fail, of course, but that way you haven't continued to persist in what might be, not the right diagnosis. 7 IVIG infusions have been wonderfully helpful. Would you call that CVID or severe hypogamma or something else? And I don't think you can make the diagnosis of CVID after the treatment. It has to be based on what you saw before the infusions were started. And if the infusions went well and the person felt better, that's fabulous, but it doesn't change diagnosis, your response to treatment, frankly. It could be that person has hypogamma, but that's based on the laboratory workup. It's not based on your clinical symptoms at all.
So a similar question then on CVID diagnosis. Started seeing a new doctor who tested my blood work while I'm still on treatment and told me I was PID, not CVID. My question is it possible for him to tell that since I'm on sub-Q and my IgM and IgA are in the normal range since I'm on treatment? Again, these are graduate level questions. So immunoglobulin would not make the IgA and M normal. That will be your own production. And this fine line on that spectrum that you saw on Charlotte's slide yesterday, where something that is a category of hypogamma or unclassified hypogamma sits next to but is not the same as CVID, where the definition sets now have got more stringent to try to better define the group. And I don't think in any of the definitions you can have both normal IgA and M. So that's not to say that IgG is low and that that individual benefits from and requires antibody replacement because they have a low G and they don't make vaccination responses and they have infections. So there is, in a sense, no reason that that should jeopardize the supply of immunoglobulin, but I know that there are some differences in terms of supply and prescriptions here. Another hopefully quick question, is there a way to test T cells and B cells while on IVIG, or does it need to be stopped? So, and the patient is 10 years old on weekly infusions. I would say that in fact you can certainly measure T and B cells while on immunoglobulin, and perhaps there are some minor changes that would happen just after an IV infusion if you look very carefully, but in general those are measured by flow cytometry and that should be possible.
Okay, too many asthma medications cause hypogamma. Steroids can definitely lower the IgG level, so the answer is yes. Will it give you CVID? No, but it will lower your IgG level, and the total protein might also be a little bit low. Your globulins may be a little bit low. It actually doesn't change the quality of the antibody very much, but it certainly can lower the levels. Will IgG therapy make asthma better? That's a tough one. If a person has an antibody deficiency and they're getting so-called asthma, which means, you're getting some wheezes because there's a bug and there's an infection, then it might actually be better. We actually did a study on the use of IVIG therapy in patients who had asthma without an immune deficiency. And the honest truth is that the study turned out to be negative conclusion, but there were a few patients who got better. So, was our evaluation of that patient so perfect that we didn't know they had a little bit of an effect and we just weren't able to detect it? Or was there some benefit that we hadn't perceived? But generally the answer is, does IVIG therapy make ordinary everyday asthma better? No. Is hypogamma CVID? Hypo, from the Greek, always means under. So gamma, you know what that is, are gamma globulin. So under gamma globulin means not enough of it. So technically, everyone with CVID is hypogamma, right, because there's not enough gamma globulin. So is hypogamma the same? That's the same question. This is a similar one, DX. 15 years ago, I was hypogamma. Over the years, it was changed to CVID. That means the diagnosis got a little sharper. Somebody went back and did a little more work and said, okay, the levels are low, the IgA and the IgM aren't normal. and the antibodies maybe aren't very good either. So that was why it got a little bit more refined, I would say. So CVID is a little more of a refined, characterization of what that hypogamma was maybe all about. I have hypogammaglobulinemia, low IgG, and did not hold on to antibodies in pneumococcal vaccination. Am I any more likely to develop CVID or a low IgA or IgM than the general population? That's a tough one, and I think the literature would say maybe. I'm not sure I've actually seen it actually happen for somebody sort of evolve from a sort of a specific antibody deficiency into pure everyday, obvious, clear-cut CVID. I don't think I've actually seen that happen. But this person has a rather bad response to vaccines and the low IgG. And of course, all that means that that person probably needs immunoglobulin, but probably will not ultimately go down the whole pathway that we were talking about yesterday about CVID. Todd has a fabulous question over here, and I think you'd probably like to know what he has to say about it.
Did you ever tell your coach or teammates about your diagnosis? Why or why not? I made a conscious decision that I wouldn't tell my coach in college that I had an immune deficiency. Primarily, it was because something very sensitive. This is 1983, and AIDS was in the conversation, and I didn't want any thoughts sprinkling in, from the vague component of AIDS and the stigma. And when I say vague, I'm talking about my illness. I did end up telling him my senior year. I had a meltdown. I was ineligible my first semester. And I think it was inside me the whole time that I wanted to tell. I wanted to at least get credit maybe that I'm succeeding with this illness. I found out I was ineligible my first semester. I was named captain my senior year, and I was ineligible because of a transfer status that was unveiled later. So I just had a meltdown in his office, and I said, Coach, I have a disease. I just said it like that, and I was crying, and he was confused and perplexed. But and it turned out all good. It wasn't a game changer as far as him with his perspective towards me. As a matter of fact, this convention is highlighting my relationship with him as well, even more. And I want to call him, quite frankly. He's in his late 70s, and he's meant so much to me. And I spoke about him in my presentation. And he truly was such a father figure that I needed at the time. So with that...
What about your colleagues now?
I indulge. I do tell them. It doesn't prevent me. I don't go out of my way in the office say, hey, I got a disease, everybody, yeah. But look at me. Don't encourage me, but I'll start going. But anyway, if somebody asks, I have no hesitation whatsoever to let them know. Yeah.
Okay, fly through something.
Okay, it's just in our perfect filing system here for the questions, there's a really good one which I've now hidden, and so I won't be able to read out, but the question was about asthma and cough, maybe due to asthma, when investigations like imaging had been normal and didn't show a pneumonia, and what to do in that setting. And I had a very interesting conversation with our pediatric chest team recently, and they use a non-invasive test to look for asthma-type inflammation in the lungs called FeNO, which is fractional exhaled nitric oxide, so literally like a blowing test, and it's an inflammatory marker that you blow out just in your breath, and it relates very closely to asthmatic inflammation. And if that is high, they then adjust the asthma treatment rather than it being infection or viral or another type of inflammation. So I was just prompted by that question.
We only have one more question we can do. We're going to take every single question here, so don't worry. Every single one of these, we're going to put them all up
Yeah, we collect the questions. They're coming back to the IDF office. We do use them for future publications in our newsletter. We have an e-newsletter. I do the Q&A for that. So we do use the questions, and they will eventually get answered. So you can always check the publications.
This is a really quick one. And it says, I'm a nursing student as well as married to CVID patient. Can I have a copy of the PowerPoint presentation? And I think we all said yes.
Yes. Yes.
Okay, so how do they get that?
So they'll be able to, all of the presenters opted as to whether they wanted to make it available, and that will be eventually available on our website. So you can check back with IDF in about a week or so and see where those are located. We may send out an alert as well to, I don't know if they're going to do it through the app or just, through our social media, that the presentations are up.
Can I just have one more question? I'm just looking at this one. I'm 31-year-old female CVID. I'm thinking of having kids in the next 2 or 3 years. Any concerns with pregnancy? The answer is a resounding no. I've had lots and lots and lots of my patients have babies. I've had a couple of sets of twins, actually. The only thing to remember about that is to keep your gamma globulin levels up. It'll take more in that last trimester. The other thing, just pragmatically speaking, get your last set of treatments well before your due date, because the last thing you want to do after giving birth is to think about how you were due for your gamma globulin. Okay? Just practicality here. Okay? And current research regarding the likelihood of passing on to the kids. That goes to the genetics question, and that's an evolving field. And I think we probably need something on the IDF website about genetics, because there were other questions
there was a
here
presentation
about
more specific
about genetics, so we probably want to do a little bit more about that. Currently, the chances are relatively slender, but there are a few situations in which that's not the case. But for most situations, it does not turn out to be an affected individual. Not that it doesn't happen, but most cases, that's pretty much the size of it.
Okay, so can we give our panel a big round of applause?